communication and an engaged, empowered, and enabled population, it's never too late to turn the tide. In Europe, countries have done it. In Asia, countries have done it. In the Pacific, countries have done it. In the Middle East, countries have done it. In Africa, many countries have done it. In the Americas, countries have done it. And in the Pacific, countries have done it. In every region, countries have been able to develop a collective blueprint for suppressing the virus and working to save both lives and livelihoods. WHO will continue to support national action plans through our regional and national country offices and spread these lessons of success across the globe. This is a critical moment in the outbreak response. We urge every single leader to strengthen their response, put targeted measures in place that we know can suppress the spread, ensure that health systems and workers are protected, and saves lives. For us all, the fastest way for us to get through this is to act together. If we all keep doing the basics, physical distancing, hand washing, mask wearing, coughing and sneezing safely away from others, avoiding crowds, and keeping windows and doors open when you can't meet friends and family outside, together we will suppress this virus. And when we are able to successfully control it, it's important governments keep going. Stay vigilant and be ready, and keep investing in your national health systems, including contact tracing. As well as focusing on their own national context, it's important to also drive global solidarity by investing in global public goods. This week, we were pleased that countries stepped up and announced $1 billion of new funding for the ACT Accelerator, which is driving progress on diagnostics, treatment, and vaccines. On Monday, we announced that WHO had approved our first antigen-based rapid diagnostic test for emergency use listing and had secured supply of 120 million tests for use in low and middle-income countries. The emergency use listing procedure streamlines the process by which new or unlicensed products can be used during public health emergencies. It's designed to provide information to procurement agencies and member states using an essential set of quality, safety, and performance data provided by the company. Today, we're pleased to announce that we have finalized approval for a second antigen-based rapid diagnostic test to be granted emergency use listing. These tests are simple to use and provide reliable results in approximately 15 to 30 minutes, rather than hours or days at a lower price. And we have also published today a call for expressions of interest for manufacturers of COVID-19 vaccines to apply for approval for pre-qualification and/or emergency use listing. Like with the new rapid tests, WHO looks forward to receiving expressions of interest for COVID-19 vaccine. Then, through our ACT Accelerator and COVAX facility, we will ensure that any vaccines that are proven to be safe and effective are rolled out equitably across the world. I have said it before, but it's worth repeating. Sharing finite resources from tests to therapeutics to vaccines isn't charity. It's the smart play for all countries, as it will ensure that they can protect those at most risk, like frontline health workers, and ultimately across the world, this is the strategy to save lives, stabilize health systems, and ensure a truly global economic recovery that helps us to recover together. I'm pleased to say that 168 countries have now joined COVAX, and another 25 have told us they will do soon. This sends a very powerful message of solidarity across the world, that we are uniting to end this pandemic for the sake of all humankind. There is something very important I want to speak about now. I want to address some of the disturbing news from the Ebola response in the Democratic Republic of the Congo regarding reports of alleged sexual exploitation and abuse by people identifying themselves as working for WHO. To be very clear, we are outraged to read these reports. WHO works around the world in the toughest emergency environments and situations in the world. We come to save lives and spread hope. The betrayal of people in the communities we serve is reprehensible. We will not tolerate behavior like this from our staff, contractors, or partners. Anyone identified as being involved will be held to account and face serious consequences, including immediate dismissal. I have initiated an investigation of the specific allegations as well as broader protection issues in health emergency response settings. WHO has a zero-tolerance policy with regard to sexual exploitation and abuse. I take these reports very seriously, and I will have more to say on this very soon. Before I turn back to Fadila, I want to leave you on a message of hope. Yesterday, on International Day of Older Persons, I had an inspiring conversation with Captain Serto Moore, who raised nearly £40 million for the United Kingdom's National Health Service with a charity walk. And just today, we received a message from Janet Bank of Durban, South Africa. Janet, we know you follow our press conferences, and I want to say hello. Thank you for the beautiful key rings from Mozambique and Zimbabwe, and for letting us know about the amazing story of Ida Ezekweti, who at 99 years of age was able to defeat the coronavirus. We're all in this together and across the world. We will continue to drive science, solutions, and solidarity until we beat this virus together. So from myself, Mike, my general, Maria, and thank you also for sending another one to my daughter, and to Gabi, we all appreciate and express our gratitude for your gift the whole way from South Africa. Thank you so much, and one day we hope we will be able and will have a chance to see you in person. Thank you so much.
Thank you, Dr. Tedros. We will now open the floor to a question from journalists. I remind you that you need to raise your hand. Use the raise your hand function on Zoom in order to get in the queue to ask questions. I would like to just make a small correction. Today, unfortunately, we do not have Portuguese translation, so apologies for our Portuguese-speaking journalists. I would like to invite Michelle Cortez from Bloomberg News to ask the first question. Michelle, can you hear me?
Yes, I can hear you. Can you hear me?
Not very well. Hello, Michelle? Michelle? Can you please unmute yourself?
Can you hear me?
Yes, now very well. Go ahead,
Perfect.
please.
Thank you so much. Yes, I wanted to ask you first if you can walk us a little bit through the case fatality rates that we're seeing here, the most updated numbers, of course, around the ages of, say, 60 and 70. Wondering, of course, I know you won't want to speak specifically about President Trump, but just what expectations are given the circumstances and whether or not the amount of social distancing, mask wearing, that type of thing that we're seeing at the White House is appropriate. And then on a completely different topic, a question on why Spain has had such a severe outbreak while Italy hasn't at this point. Thanks.
Thank you, Michelle. I would like to invite Dr. Maria van Verkock to take your first question.
Thanks very much for the question. So the estimates of the case fatality ratio, which is the estimates of the number of cases of deaths over the number of cases of reported, to date vary greatly by country, and they varied greatly over time. One of the things we know about the risk for severe disease and death is if you have underlying conditions, if you are of older age, above 60, above 70, above 80, you have a higher risk of death. What we're looking at in terms of the case fatality ratio, it's a crude estimate because estimates of mortality are underrepresented at the present time. And so they're crude. That's why I say that they're crude. And they vary by country. In some countries it's less than 1%. In some countries it's over 20%. But we do know that the case fatality ratio increases by age. The other measure that we look at is what's called the infection fatality ratio. And this is the number of deaths divided by the number of total infections. And you've heard me say before, there are some estimates of the infection fatality ratio, which overall is around 0.6%. But that also increases dramatically by age. And so what we advise, as we have advised from the beginning, is a comprehensive approach to not only prevent people from developing severe disease and dying, but also to prevent infections. Because the more infections we have, the more opportunity there is for those infections to reach people of older age who are at a higher risk of dying.
You asked specifically about the differences between Spain and Italy. Perhaps Bruce may also be able to offer some insights in that, given that he's worked closely with our regional team and with both countries over the last number of months. I think it's very difficult to compare countries at any particular moment because the evolution of their epidemic is at different stages. Clearly, Italy, way back earlier in the pandemic, was perceived to have done badly because it was hit badly and taken unawares. And then as it recovered, we saw the numbers in Spain deteriorate. This time round, Spain has had a deterioration earlier. Italy, in that sense, has coped better. But as we spoke again previously about Africa and other places, it's very hard to say that people are out of the woods. Relative performance versus just unpredictable events that can occur and can amplify disease in particular settings and can set off these brush fires, particularly in urban settings, that can be very difficult to control. We've seen that in Australia, we've seen that in China. You can have very small events that can actually spark a major issue within an urban setting in particular, and that can make a country look very far behind the curve. We also have the artifacts of testing and other things that we have to be very careful when we compare countries. Both countries have really had to fight very hard. Both countries have really had to adapt their systems. They've had to dig deep to improve their public health systems, to shore up and strengthen their health systems, and really has required a massive social effort. And you certainly see that particularly in Italy, where there's been a huge reimagining of the social contract that I think is having a great impact in keeping the disease under some degree of control. But Bruce has been much closer to offering direct technical advice. You may wish to make a comment on either country, Bruce.
Thanks, Mike. I think I would first just add to Mike's recognition of the extraordinary response that we saw in both countries, both Spain and Italy. When working in both countries, in Spain in particular, it was just extraordinary. The breadth and depth of the response, the commitment of the healthcare workers, of the ministries, of the governments, at all levels, but of the general population. Madrid was an extraordinary place, as was Barcelona and the other places we visited while in the country, to see that level of cooperation and solidarity in trying to beat this virus, and very much reflecting, I think, some of the advice you, the Director General, have always been giving countries and individuals. You really saw it play out in both countries very impressively. And I think, to the point Mike made, we're dealing with a biologic process, and we don't understand everything about this virus and everything about why it takes off in some places and doesn't in others. And when it takes off in some places, undoubtedly what we're seeing is a very rapid and sometimes very subtle shifts in behaviors in other countries that just help keep them from hitting a tipping point. It's clear that there's tipping points with this virus, and as soon as you get behind that 8 ball, it's very, very difficult to get it back. So part of this is like Mike said, it's bad luck, because in both countries you've got very, very impressive responses, very well-trained people, and populations that really know what they're doing. So I think at this point our thoughts really with the Spanish people in particular, who are going back into some very, very difficult decisions right now as they try and get this virus back under control. And I think we have full confidence they will, because they've got the experience, the expertise, and the commitment to do that. I think we'd also note, and Micah, you may have mentioned it, that there are parts of Italy where we are seeing it's heating up, and they're moving very, very quick to try and address that as well.
Thank you. I would like now to invite Catherine Fioncan-Bokonga, France 24. Catherine, can you hear me? Okay, I would like now to invite Agnès Pedrero, AFP. Agnès, can you hear me?
Yes, I can hear you, Fadela.
Yes.
Hello, everybody.
Yeah, we will come back to Catherine later on, but Agnès, we can hear you very well. Go ahead, please.
Yes, thank you. I will ask a question that was just asked, but I didn't listen any answer. I wanted to know if you think that the US president disregard for the mask had made it inevitable that he would be infected at some point. Thank you.
Mike Ryan, Dr. Mike Ryan, please.
Yeah, I think we don't generally comment on the behaviour of any specific individual, and we don't know what risk management measures were in place around any given individual, especially someone as prominent as a president. What we will reiterate is that each and every individual and each and every citizen should be guided by the national guidance in their country, and that the combination of different measures that reduce risk, and we know these reduce risk: washing your hands, staying a safe distance from other individuals, avoiding crowded spaces, wearing a mask, both to protect others and yourself in situations where you can't physically distance or where there's a risk, and doing all of that to protect yourself and others is the best way to protect society. Our advice doesn't change, but we will not comment on the specific risk management measures or behaviour of a specific individual. We are a community. We need to get through this together. This is not the time to turn on each other.
Thank you, Dr. Ryan. I would like now to call for the second time Catherine Fioncan-Bokonga from France 24. Catherine, can you hear me?
Yes, Fadela, thank you so much. This time I got the sign to put my sound. Thank you. Good evening to all of you. I would like to come back to the allegation of sexual abuses by Ebola aid workers, as I know that Dr. Mike Ryan and Dr. Tedros did follow very closely what happened in the fight against Ebola. I would like to have their reaction on that, and also about the fact that apparently the women that complained were drugged, abused, locked up? And could you give us more details about the WHO people involved? Because we know that people from other agencies and NGOs apparently are also involved. And will you share some reports with names with the press when you have evidence? Thank you.
Thank you, Catherine. Dr. Ryan?
Thank you. We simply don't have any of those details. We have what you have, which is the report in the newspaper. We start from a position of believing those individuals who have suffered abuse or exploitation. That is the first. The second thing, we are absolutely concerned that the individuals who have been abused and exploited receive the proper care, the proper support, and absolute access to justice and a bright future. And we will do everything possible to make that happen. But frankly, right now, we have absolutely no details of any of the individuals, any of the specific allegations. I know David Webb, who leads our more internal and investigational side, and others throughout the UN are working together to establish how much information may be in the system, and they will work. I know that the Director General will and is launching an independent investigation and will make announcements. He said he will make announcements in the near future on that. So the organisation is taking this deadly seriously. These allegations are horrific. And it is awful to hear. And both the Director General and myself spent significant time in the field. I feel terrible to hear these stories. I feel awful for the people affected. I feel awful for their families. I feel awful for the wonderful WHO, the NGO, and the UN staff who have risked their lives over the last 2 years and given their lives to help these people. To think that any group or individual would destroy and degrade our image or the lives of other people is just almost too much to contemplate. But we first have to get the facts. We first have to get this properly investigated. Right now, we have no more information than you have. We will and are actively seeking that information. But we also need to ensure that we're very sensitive in the way we do that, and that those affected by this are not further traumatized by the process.
WHO's Dr. Mike Ryan answering a question there about incidents of sexual abuse reported in the Democratic Republic of Congo earlier on. The Director General Tedros Ghebreyesus speaking about this, saying that he's very saddened by these reports of abuses by alleged WHO aid workers, saying that this kind of behavior will not be tolerated by the WHO, and says it's been fighting very hard to end the Ebola crisis in the Democratic Republic of Congo. And this comes as a very sad news, saying that they are definitely instituting investigations, and anyone found guilty of this will be summarily dismissed. And of course, a question that was asked several times is on the WHO's response to news that US President Donald Trump has tested positive for COVID-19. Mike Ryan deftly answering that question, saying that they are not in the business of zoning in on individuals. All he can say is that they encourage every individual to follow the safety protocols of their own countries, also emphasizing the fact that, as he says, we are a community. We should not be turning on each other at this point. Well, US politicians doing this. This is something we'll find out about later on when we have a full-on debate looking at President Donald Trump testing positive for COVID-19, including the First Lady, and how they're going into quarantine. What does this mean for the rivalry with his presidential contender rival, that is Joe Biden? That's all coming up later on. But for now, the U.S. House of Representatives Speaker Nancy Pelosi says plans for continuing government should President Donald Trump become incapacitated remain in place. This after Trump
monitoring and in our disciplinary procedures. And we will look at each and every one of those processes to ensure that this is dealt with definitively and decisively, and the organisation will not stand back from making that happen quickly and also in the best interests of the victims. And again, I will say, the victims are to be believed. It is our job to do the appropriate investigation.
Thank you, Dr. Ryan. I would like now to invite Ashley Furlong from Politico. Ashley, can you hear me?
Yes, I can hear you. Can you hear me?
Yeah, very well. Go ahead, please.
Thank you. So the European Medicines Agency just announced that it is investigating reports of acute kidney injury in some COVID-19 patients taking remdesivir. Could you comment on that? And is this not going to be a massive blow, possibly, to the very small arsenal that we have to treat COVID-19?
Ashley, can you just repeat your question? You were very quick.
Yes, sure. So the European Medicines Agency has announced that they're investigating reports of acute kidney injury in some patients taking remdesivir. I just wanted to know if you could comment on that.
Dr. Swaminathan, if you want to take this question, or Dr. Simao?
We are collecting data on all the investigational drugs. As you know, we maintain a living review and a meta-analysis of all the ongoing trials. And remdesivir is still being tested in trials, and at the same time, of course, it's also being used to treat patients on an emergency authorization or a compassionate use basis. So we will be reviewing this periodically. I have not heard specifically about this particular report from the EMA, but we can certainly investigate and come back to you on that.
Thank you, Dr. Swaminathan. I would like to introduce one of our experts. Yes, Emmer Cook, who would like to add some comments to this question. Dr. Emmer Cook, she is the Director of Pre-Qualification and Regulation at WHO. Dr. Cook, you have the floor.
Yeah. Thank you very much. Yeah, just to say that we are in very close contact with the European Medicines Agency, and we follow any investigations that they are doing. As far as I understand, this investigation is at an early stage of development, but we will be in touch and make sure that we follow up and liaise in terms of the trials that are ongoing.
Thank you. I would like now to invite John Zarakostas, France 24 English service, to ask the next question. John,
yes,
can
hello.
you hear me? Yes,
yes,
John.
Hello?
Yes.
Yes, I can hear you. Yes.
Go ahead,
yes,
please.
Good afternoon.
Hi.
Firstly, I'd like to get some comments from the experts around the podium on the press release by WHO Africa on the 24th September that said a mix of socio-ecological factors might be behind the lower infection rates on the continent, and it listed among the factors hot and humid climate along with low age groups, etc. That comes as news to me. Is there any evidence behind this? Thank you.
Dr. Van Kerkhove, do you want to?
So I can start. Yes, I can begin. So yes, I mean there are different. We know that this virus circulates in all countries all over the world. It has circulated in all types of climates: cold conditions, hot conditions, different types of humidity. The virus operates in clusters. It operates where people are in close contact with one another, and it can spread very rapidly in those types of situations, particularly when you're indoors, you're crowded spaces, there's poor ventilation. What we do know in different types of climates, people act differently. When you have warmer climates, people tend to spend more time outdoors than they spend indoors. We're noticing that in the Northern Hemisphere as we enter the autumn. And as weather gets colder, people will tend to spend more time indoors than outdoors. I think there are a number of factors of why we see differences in the circulation of the SARS-CoV-2 virus in Africa, as has been outlined by the press release that you indicate. But indeed, this virus spreads where we allow it to, in a sense, because this virus is controllable.
If we speak to the specific issues that pertain in Africa, and again, I'll remind you, as the DG reminded us last week, when we speak about Africa, we're speaking about 54 different nations on a continent. 55. Sorry, boss, I got it wrong. Therefore, we can't put all of that experience into one description of what's happening. There's a huge diversity of climate, of population, of economic development, of social inequalities, and so many other issues. Having said that, we did have a very interesting conversation during the week with the director of Nigeria's CDC and some other health leaders around the world, and that question was actually put to Chikwe and some other Lucille Bloomberg from South Africa, because people are intrigued, and naturally intrigued, as to why Africa seems to be avoiding the worst of this pandemic up to now. And that's a good question to ask, because you can learn lessons in asking that question. Part of that is certainly due to population demography, because with half of the population of Africa being 19 years or younger, and very, very few relatively percentage-wise of people being over the age of 65, it may mean that we have a higher incidence of disease in Africa, but a much lower mortality, just by nature of the fact that it's a younger age profile. And the fact that some countries in Africa probably don't have enough testing going on, they don't have the resources, and therefore maybe under-detecting the incident cases. So that might create an impression of fewer cases and fewer deaths. The fewer deaths is real, the fewer cases may not be as real. The other thing is that while Africa is increasingly becoming an urban environment, large parts of countries are relatively not so densely populated, and it may be that the virus finds it hard to establish and spread in some of those environments. There are many other reasons, but I think I will point you back to some of the positive reasons. And I remember, again, speaking with Chikwe and others during the week, and people were asking, so, you know, in terms of Africa's first reaction, and how did you manage to keep a lid on this? And I think Chikwe said, you know, we just treated this like any other outbreak. We went after the virus, we investigated, we detected the cases, we identified the contacts, we isolated the cases, we asked the contacts to stay at home, we tracked and traced, because we've had Lassa here, we've had cholera here, we've had monkeypox here. We've been doing this for years and years and years and years. And what it probably demonstrates is that in many countries in Africa, there is a very well-practiced, well-trained core of public health people. It may not be a huge army of people, but it's a very, and if we take polio eradication, been something, again, in Africa has generated huge numbers of individuals who know how to investigate cases. They know how to respond to clusters of disease. So paradoxically, countries in Africa may actually be well ahead of countries in the rest of the world in terms of their instinctive response to how to deal with an epidemic. And countries in the industrialized West and North may have lost that muscle memory. Equally too, and this is something I think I've said here before, in Africa, public health practitioners, doctors and nurses, others, have instinctively think of how the community is going to deal with a problem, the community issues associated with a public health threat, just as quickly as they think about intensive care, just as quickly as they think about other things. It's taken many countries a long time to move from a biomedical concept of this disease to a community concept of this disease, to how to stop this disease in the community, how to work with the communities on behaviour, how to empower communities. Many of my African colleagues have learned many years ago that unless you get the community on board, you're not getting anywhere in epidemic response. So I do think, while there are factors, epidemiologic and others, that might explain why Africa is not as impacted, I think we should also give credit that there's instinctively a very good public health response in many, many countries in Africa.
Thank you, Dr. Ryan. I would like to give the floor to Dr. Maria Verkov, who has some addition to make.
Yeah, I'm sorry, I want to come back in again because I was trying to keep my answer quite short, but there is data that comes from Africa. And one of the things we look at is the seroepidemiology studies that we've been talking about. And so maybe there may be differences in surveillance and testing capacity. There are a number of seroprevalence studies that are being done, and these are studies that measure unrecognized cases as they test for antibodies, which is an indication that there had been past infection. And to date, there are more than 150 publications on seroepidemiology, 10 months into a pandemic. These are peer-reviewed publications and preprints. 5 of those are from our African region. And similar to other parts of the world, the results of those is that in the general population in non-outbreak settings, the seroprevalence is below 10%, which is similar to what we are seeing in countries all over the world. There is one study from Nigeria that looked at healthcare workers and found a higher seroprevalence, again, similar to what we are seeing in other countries. So there shouldn't be any suggestion that countries across Africa, and again, 55 countries, very different, incredible responses, very aggressive, using that public health infrastructure that is in place and that has been strengthened over decades, are looking and they're seeing different levels, they're seeing the same levels of seroprevalence that we've seen in other countries. So I just wanted to add that because this is a growing body of evidence that is helping us to understand the extent of infection in all countries across the world.
Thank you, Dr. von Kerkhove. I would like to invite Michael Busiorkiv, who is a contributor to CNN, to take the next question. Michael, can you hear me?
Yes, I can hear. Merci beaucoup, Fadila. Bonjour tout le monde. I had a question, not specifically about President Trump and the First Lady, but you know, they're not the first heads of state to succumb to the virus, of course. And as we have found in other pandemics and outbreaks, heads of state are crucially important in public health messaging and signaling, especially when it comes to the importance of things like mask wearing. I'm wondering if you have any thoughts on when heads of state get the virus and recover it, that their public messaging can become even more effective or impactful. And just quickly, I reference you to what Honduras President Juan Orlando Hernandez said after his recovery. He said, many think that this is a game, and it's not until that they see a relative who gets sick or when they get sick themselves that they understand the seriousness of this issue. The truth is, I don't wish this on anyone. Thank you.
Yes, thank you. I'm not sure that was a question, but it's again, we wish the President and his partner well, like we would wish anyone facing this disease well. This is a nasty virus, and this virus can cause severe disease, particularly in older individuals with underlying conditions. So we wish the President and his partner well in this process, and anyone else who's affected within that cluster. Disease can be transformative. We've all been through things in our lives, health events that transform our lives whether we want them to or not, and therefore and other things that allow us to learn and absorb lessons from our lives. We want everyone possible in the world. We want all public leaders, particularly leaders of great countries, to lead us and to give us hope, to give us certainty, to give us truth, and to give us a chance to fight and win against this disease. So it is never, ever, ever too late for that to be true. And therefore I hope that all leaders around the world in health, in medicine, in politics, reflect upon what we're all facing, and that we can all come together to fight this disease, and particularly to be very practical, to each government to invest enough in its community, in its surveillance, in its clinical care, so we can bear the burden of the disease for now and push the disease to the lowest possible level. But as well, and I say this quite clearly, there is a solution potentially coming down the line. There is huge innovation developing the vaccines, the therapeutics and the diagnostics that we need. There is a barrier between us and that achievement. And it is a relatively small amount of money when we think about what has been spent and what has been drained from our collective pocketbooks from the global economy. This vaccines particularly don't offer an absolute final guarantee of getting this done, but they are a massively important tool, as they've proven themselves to be in the past. So I would say fine words are fine, and we need those words, but what we need now is action. What we need now is investment, and what we need now is solutions. And I hope everybody can reflect right now as we send our best wishes to the President and his spouse, that we can redouble our efforts, find the right investments and get this job done.
Thank you, Dr. Ryan. I would like to thank Dr. Tedros and my colleagues today for their participation, and to journalists who are following us very regularly. I would like now to close this briefing and remind you that you will get the DG opening remarks as soon as this press conference is over, as well as the audio file. The full transcript will be posted on the WHO website, most probably tomorrow morning. As always, I would like to apologize to those journalists who could not get their questions answered. Thank you so much, and see you next week. Thank you all. Have a nice weekend.